Tokyolive
Endoscopy 1.
Welcome everyone to Tokyolive Endoscopy 1. Today's session is current status of ESD in America. We have exceptional speakers from North America and South America. The Professor Nishimura will be speaking from North American side, and Professor Miyajima will be speaking from South America side. We really appreciate your invitation, Haru, for this exceptional course. And we really want to be in person, but this is fantastic that we organize in this fashion, and we continue to educate the doctors in the world. So I would like to start the session by introducing Professor Nishimura. Professor Nishimura is currently at Memorial Sloan Kettering in New York City. He graduated medical school, Jushi University Medical School. And he has been well trained in Japan for so many years. And then he was accepted to be trained at prestigious University of California, Irvine under the guidance of Dr. Kenneth Chan, and he acquired additional skills in EUS ERCP and interventional EUS as well. He's an expert in endoscopic submucosal dissection, and that was the main reason that he was just loved and requested to be part of the faculty at Memorial Sloan Kettering Cancer Center. So we're honored to have you, and we would like to ask you to start your presentation. Thank you, Makoto.
Yeah, thank you, Dr. Fukami, and thank you, Dr. Inoue. So it's my great pleasure to be able to have a presentation at Tokyolive. So let me share my screen. So today I would like to talk about installation of ESD in North America. This is my disclosure. As background, ESD has gained popularity all over the world, especially in the United States. However, there is still a gap between East and West. So what's the issue to install ESD in North America? So today I want to talk about what's the difficulty. So there is a gap between Japan and the United States, including the etiology and the diagnosis or devices and education. So briefly, the history of endoscopic resection or third space endoscopy in the United States. So after gastroscope was developed in Japan in 1950s, Dr. Shinya started polypectomy in New York 1969. And in 1980s, the EMR and 2000, the ESD was developed and delivered to the United States. And right now, so many people is doing ESD poem, G poem, and Z poem in the United States. So Japanese style therapeutic endoscopy has been modified to American style. So this is very similar that sushi modified to American style. We don't eat dragon roll in Japan, but people like dragon roll in California and United States. So difference of etiology in the both sides. So this is my personal ESD data in Tokyo and New York. In Tokyo, I have been used to do ESD about 40% stomach case and about 40% colorectal case, 12% esophageal, and a little bit duodenal ESD cases. And in New York, of course, the most huge demand is colorectal ESD. It's about 60%. But we have 80% gastric ESD cases and 8% esophageal and duodenal cases. Of course, in Japan, the squamous cell cancer is more than 90%. And On the other hand, in the United States, most of the cases of the esophageal cancer is adenocarcinoma, and a very, very small percentage of the squamous cell cancer. In Japan, the NBI or Lugol staining are used to detect, to find the esophageal cancer, and after ESD performed, the surgery or radiation or chemoradiation are considered for non-curative resection. And in United States, basically esophageal adenocarcinoma were found by the 4-quadrant biopsy in surveillance endoscopy for Barrett's esophagus. And many patients refer to ESD. And even after curative resection, the radiofrequency ablation is used for background Barrett esophagus to eliminate the Barrett tissue. And also, for non-curative resection patient, the surgery or chemoradiation or photodynamic therapy or the brachytherapy are considered in my institution. This is NCCN guideline in the United States. And now we can see here that even after the endoscopic resection, the guideline recommend the endoscopic resection or ablation. So this is a difference from the Japan. So these are typical esophageal ESD cases in my institution. 75 years old male with adenocarcinoma found by random 4-quadrant biopsy outside the institution and recommended esophagectomy. And we could identify the lesion, and we did a curative ESD in one piece, and followed by RFA. And the second patient, this is a 62 years old male with Barrett esophagus, and found adenocarcinoma by random biopsy. And we did curative ESD and followed by RFA. Third patient has a high risk of the surgery because of the comorbidity. So this is a 58 years old male with a GE junction cancer, and EUS shows very deep invasion into third layer. So usually this is not a good indication for adenocarcinoma, but because of the thoracic surgeon wants to remove first. So we removed, and we are following this patient very strictly. So this is a kind of typical esophageal ESD in my institution. The patient had Barrett esophagus and found adenocarcinoma. And after RFA twice, the patient had a history of RFA twice. And now we can see very, very thick mucosa. But in the submucosal layer, we can expand. So this is a pro knife. So this is an unblocked resection. So basically, this is not a good indication for esophageal ESD and different from Japanese indication. For stomach, in Japan, mainly gastric cancer are related to H. pylori gastritis and intestinal type. And in the United States, in the US Cancer Center, we are experiencing less H. pylori related gastric cancer and more diffuse type gastric cancer we have. Especially the CDH1 mutation patient is one of the biggest and important hereditary gastric cancer in the cancer center. This is known as invisible cancer. So one study from our institution shows about 40% patients already have multiple gastric cancer in the stomach in the gastrectomy specimen. So now these pictures, a pale area or erosion polyp, a known target for biopsy for CDH1 mutation patient. About colon cancer. So still there is a discrepancy between Japan and the United States by pathologists. In AJCC, we cannot see the T1A or T1B like Japan. So still there is a control. Both pathologists is not making the same criteria. So this is my my personal ESD data for colorectal ESD. So after I moved to from Tokyo to New York, my unblocked resection rate got worse from 96% to 76%. So this is not by my ESD technique, hopefully, but due to previous tattoo or scar. So these are factors of difficulty ESD in the United States. So previous incomplete resection or previous tattoo into the region, and long-standing history of IBD. So this is also not a good indication for ESD in Japan, but very typical ESD in my institution. So the patient has a history of advanced rectal cancer, T3, and status post-chemoradiation, and tattoo inside. And the patient found residual tuberous adenoma with high-grade dysplasia. And now we can see very, very severe fibrosis. And even after a bunch of injection, we cannot see nice space underneath of the cancer. So now we can see the submucosal layer is lifted up well. So this is an unblocked resection. So this is another patient, 55-year-old male with lower rectal residual adenoma after surgery and radiation, and found the patient were referred for ESD, and I did an unblocked resection. So this is another patient who had a long-standing history of Crohn's disease, found adenoma at the sigmoid colon, and the outside physician injected tattoo inside to the lesion. And it was very, very difficult because of the tattoo and fibrosis, but I could remove in one piece. So now talking about the difference of diagnosis and device. So in the United States, so many devices are approved by FDA. So now this is an Apollo bar stitch and traction device, speedboat, or the robotic system, and full thickness resection device, and the Didumen. This is a two balloon system and traction device. And device-assisted ESD must be developed in the United States more and more by the many venture companies. But despite such trend, below a common issue in the United States. So as I mentioned, random biopsy by the outside physician, and the patient go to gastrectomy or colectomy. And CAP EMR is still very common for upper GI tract. And culture of tattoo into the region, and culture of partial resection as a big biopsy meaning. Also, most of the Japanese classification is not common in the United States attendings, like esophageal cancer classification by Japan Esophageal Society. Actually, we don't have magnified NBI in the United States. And the VS classification for gastric cancer, or Kudo-Pitt pattern, or JNET classification. Some attendings know about such kind of classification, but not all attending know, and fellow has no chance to train such kind of classification. So right now in the United States, 6 or 7 million people per year have a screening colonoscopy, and about 50,000 people a year underwent colorectal surgery for benign polyps, and it's increasing. So hopefully in the future, many American people will be able to receive ESD in all states, and they can avoid unnecessary colorectal surgery for benign lesions. So finally, I'm talking about education. So ESD training in Japan versus United States. So many American fellows are not used to Asian style ESD education, like many long years of training or very strict mentor. It is better to train American fellow in price. The problem of ESD training in the United States is lack of diagnosis training, like NBI classification or endoscopy, and limited institution, not so many high volume center, and small number of early gastric cancer, and this is very difficult for beginner, and 2 short period for ESD training. In the United States, after finishing 3 years of GI fellowship, only 1 year advanced fellowship is allowed for ESD training. However, many programs are focusing on ERCP EUS training more than ESD. So basically, many advanced fellows are very too busy to master EUS ERCP, and so they don't have enough time for ESD training. And newly diagnosed gastric cancer cases are very rare also. Only 200-300 early gastric cancer cases are found in the United States in 1 year. And therefore, like a Japanese style, step-up approach starting from distal stomach or rectum is not good ESD training method in the United States. In my institution, fortunately, we have many ESD cases a month. So fellow may attempt esophageal ESD or gastric or colorectal normal ESD without any scar. And I don't recommend to fellow to try esophageal adenocarcinoma with Barrett esophagus or post-RFA or radiation patient or GE junction cancer or duodenal cases or colorectal cases after previous incomplete resection or radiation cases. So in my institution, the fellow can start from observation and they can join as an assistant for 5 cases or 10 cases around, and they can attempt some mucosal incision. And if they are doing well, then they can attempt more submucosal dissection and full ESD. So because of the COVID worldwide, ESD training are very difficult last year and this year. And in our institution, ESD cases were dropped last year. And however, there are more frequent web seminar worldwide and YouTube video is available. And also the institution training is available. So such kind of web seminar is now increasing. In summary, in the United States, we need to modify ESD to American style, and we need to use to do complicated ESD, like a post-EMR or tattoo or RFA or post-chemoradiation patient. To establish ESD dedicated training programs should be ideal for American trainees. Thank you for your attention.
Thank you so much, Makoto. That was fantastic lecture, and covers so many aspects of the current status of ESD in the United States.
Thank you.
I would like to ask several questions and reserve more for the later time. But first, when you train the fellows, you mentioned about observation, but you didn't really touch on explant training. Do they perform explant training before the observation or after the observation? Where does the explant training comes in?
Yeah, that's a very good point. So if there is a chance, I used to let them attend such kind of hands-on course, like using the animal plant. But actually, we don't have such kind of training lab in my institution. And so that's why fellows are jumping to the real patient, usually in my institution. But totally agree. Yeah,
I think it's in real, if there's a chance, we have to make every opportunity to train fellows or new physician to the ESD on the explant to learn the techniques and basics. I think that would be really helpful. At least let them do probably 20 ESD in explant model would accelerate the acquisition of techniques so that they can perform safe ESD.
And that's much safer.
Yep. Also, you touched on the early detection. Another issue is definitely imaging diagnosis. We're so behind on the training physician on the advanced imaging, how to judge the lesion by good inspection, the features, magnification, and the digital chrome endoscopy. Do you train your fellows, or you at least try to train fellows on this the classification at the earlier in their course?
Yeah, I have been training the fellow to teaching such kind of classification. But at the same time, the fellow have a chance to be trained by another attending. And most of the time, another attending are not interested in such kind of classification.
Do you set the bar to know this much of basic knowledge before they go into the ESD?
Yeah, actually, we don't set such kind of bar.
Okay.
But
So
many times I'm teaching such kind of classification based on the Japanese knowledge.
I see. Do you have any resources that you can offer for American learners? Where can they learn such advanced diagnosis?
Yeah, so here we have some books, but the diagnosis books is written in Japanese. So sometimes I show them my textbook, but I think there's no so much English book to teach fellows.
That's a major hurdle we're facing, and I think that this has to be ongoing effort to train all the physicians, gastroenterologists, how to do the imaging diagnosis. We both trained in Japan initially, so we know how important it is to diagnose by looking at it, not by just biopsy.
Yeah, many times young fellow wants to do ESD, wants to learn ESD without such kind of the training of the diagnosis. So I think that's a problem.
Yeah. This is a true story, but ASG was the planning for advanced imaging course. And that was including live endoscopy to show how to make a diagnosis. That was probably 6-7 years ago. It didn't come to fruition because only the 3 participants registered.
Oh, really?
So they said it doesn't worth it. So there seemed to be lack of interest as well. So in any case, thank you so much for excellent presentation, and we'll get back to you.
Yeah, thank you so much for moderating.
Thank you. So next presenter is Professor Miyajima. He's currently assistant professor at University of the São Paulo University, and head of endoscopy unit of the hospital endoscopy. And he actually trained also in Japan at many prestigious institutions on endoscopic diagnosis, as well as endoscopic resections. To name a few: Akita Red Cross Hospital, Chiba University, Tokyo Medical Dental University, Showa University at Dr. Inoue and Dr. Kudo's place, National Cancer Center Hospital, and Kobe University. That's exceptional training, and we would like to hear what you see from your eyes from South America. Thank you, Nelson.
Thank you. I will share my screen. Hi, I am Nelson Miyajima from São Paulo, Brazil. First, I'd like to congratulate Professor Inoue for the worldwide Tokyolive Endoscopy 1. It's a fantastic event, and thank you for honorable invitation. It's a great pleasure to participate in this session with Professor Norio Fukami and Professor Makoto Nishimura. And congratulations, Nishimura Sensei, for this your lecture. My topic is the introduction of the ESD in South America. No disclosure. The ESD technique that gained its relevance for its purpose of the resection of GI lesions, and for being the base for other procedures such as POIN, G-POIN, Z-POIN, stairs, POF. So it is essential to master this technique. We will talk about, based on our personal experience, the difficulties and the challenges when we started ESD 15 years ago. At the time, there was no recommendation or guidance to start in this advanced technique. And maybe our report can encourage or help for those who want to start in this technique. We become interested in this technique and start studying by reading books, mostly in Japanese, with the help of my father, watching videos, lectures, and procedures in live course. This course in Tokyolive was specifically created with the purpose of improving ESD technique, which at the beginning was not very accepted due to the very high complications rate. In this course, we have a participation of the pioneers, Professor Takashi Toyonaga, Takuji Gotoda, Hironori Yamamoto, Tsuneo Oyama, Naohisa Yahagi, and Hiroyuki Ono. But according to this pyramid, William Glasser pyramid, the retention of rate of lecture, reading, and the videos method is very, very low. And I thought it wouldn't be possible to learn ESD only this way. So I asked to Professor Gotoda the opportunity to do my first training at the National Cancer Center in 2007, where IT-knife and this technique was developed. We observed many cases and performed training in ex vivo models, like this. And returned to Brazil, we held the weekly training in lab with this model, with my homemade model for ex vivo stomach of pig, and also in live pig. I believe that the ex vivo training is very, very, very efficient and cheap. We perform the first resections. It is clear that we didn't have the master of ESD technique, even in this easy case, gastric case. One of the difficult was the colleagues did just refer simpler cases like this, but the difficult case, like this case with residual lesion with scar, or in proximal column. And one challenge is that we didn't have long or proper knives for column. In this case of second, we did it with a gastroscope and IT knife, which is not the most suitable, of course. We always had the surgical team on standby for any need for intervention. Another difficulty is that we have to work with many types and brands of endoscopes, like Fuji, Olympus, Pentax, that have their particularity in terms of position and the diameters of the working channel. It's so difficult. And also the types of knife available changed. I only had a training in IT knife, but sometimes I needed to perform with other knives. Then we returned 3 times more to Japan to learn how to handle other knives and scissors and reinforce my basic fundamentals. I believe that this contact with the many experts in knives, it's important because each knife has its characteristics, and the resection strategy must be different. So we have a chance to learn from many experts. So I am so thankful to Japanese mentors, my mentors, professors. Another change is to set up a structure of equipment suitable for ESD. In the beginning, we did have a proper electrosurgical unity with soft coagulation or endocut mode or CO2 insufflator. So we helped the Brazilian companies to develop these models. But really, we had many difficulties to start ESD. Another difficulty was our scopes did have magnifications, resources, which limited the evaluation of the lesion regarding the limits and the observation of the vascular and the glandular patterns. See, in this example, there is a very flat white part in this border, very difficult to identify with white light without magnification. Fortunately, the resection was complete, but it's really difficult to work without magnification. What another limitation is the lack of hyaluronic acid to submucosal injection. Well, so we replaced it with Voluven and the mannitol. I would like to mention other comment points that I think are so important. For example, organizing workshops and live courses, inviting experts. It's a great opportunity to everyone to learn, to train, and to motivate the entire team of physicians and the non-physicians. We received many Japanese experts in ESD, like Professor Toyonaga, Professor Gotoda, Ono, Oyama, Yamamoto, Hagi, and the others. It's really important opportunity. Another important condition, or rather fundamental condition, I have a good basis in detection of in the evaluation of the gastrointestinal lesions. I had the opportunity to visit Professor Kudo at Akita Red Cross Hospital in 1995 and learned colonoscopy insertion technique, diagnosis, and the evaluation of the pit pattern classification, Kudo classification, extremely important in the decision of the therapeutic conduct or surgery or EMR or PMR, and learn the EMR technique, EPMR techniques, handling the scope with handling the control with the left hand and the hanging the scope with the right hand, what is essential to do ESD. In 1997, I have an opportunity to study esophagus disease with Professor Teruo Kozo at Chiba University, Professor Makuchi at the Tokai University, and with Professor Haruhiro Young. He was very young at Tokyo Dental Medical University. At that time, Professor Inoue had developed the EMR cap technique, and he was already studying IPCL. Later, I had the opportunity to visit Professor Ken Xiao of Fukuoka University, Kazuyoshi Yagi, then at Yoshida Hospital, and Norio Uedo of Osaka International Cancer Center. These fundamentals in detection and diagnosis were very important for me to find my own cases like this to start my in ESD. Like this case with very small gastric lesions And also important chromoscope magnification technique, we are essential for some case like this, for a precise delimitation of at the time of resection. It's a very tiny lesion, it's with magnification, and to, of course, increase our detection capacity for benefit of the patients, and also to increase our number of cases, finding synchronous or metachronic lesions like this. This patient had 2 lesions here and another lesion here. And a few weeks ago, I find the same patient who had that opportunity to find this lesion. We have also been to several other institutions to perform ESD, so we can increase our case in addition to benefit patients with this technique, avoiding surgery in many cases, and they share our experience. Finally, I would like to bring some points that I think are relevant for learning ESD: cognitive training, observation of ESD, software-based training, training courses, self-guided hands-on, which for me was fundamental for my development, expertise in MR, hemostasis, clipping, assisting at ESD. I think it's, if you have the opportunity, it's very, very important. Lesion evaluation, detection, as I told you, it's very important, And the organized courses to have contact with experts. Thank you very much for kind attention.
Thank you very much, Professor Miyajima.
Thank you.
That was very fun to watch, and it's impressive sizes that you showed towards the end of the lecture.
Thank you.
First, would you clarify self-guided hands-on that you felt like most important for you? What does that self-guided hands-on mean to you?
Okay. When I back from Japan, I did my support to training with ex vivo specimen. So I trained, and of course I was starting. So my level is too low level of technique, but I shared experience with my fellows, so I could improve, and every week we could do it. And its advantage is you can do it in any time, and it's very cheap. So I think ex vivo model, I think it's fantastic, in my opinion. Yes, it's
Thank you.
Yes.
How many ESD did you have to do on explant until you feel a little more comfortable?
I think depends on depends on your background, maybe. If you have, when I started the ESD, I have more than 10 years of experience in procedures. So I think about the 30, after 30 cases, I think, of course, in easy case, because of, like Professor Nishimura told us, we have many difficult cases with tattoo, scars. So in Brazil, I think it's the same in the United States, we have a very challenging case, more than in Japan, in average, of course.
Great, thank you.
Thank you.
Last question before our group discussion. Now, you learned so much from going to Japan at the the expert centers how to do advanced imaging and diagnose by careful evaluation with endoscopic images or imaging per se. How did you bring back to Brazil? What is the step that you're taking to educate young generations? How are you doing right now?
I think a good question, Professor Fukami. I think it's we try, but we have culture. It's a little different. Dr. Nishimura and Dr. Fukami, I think you know, it's the culture is a little different. So I think we need to every day to teach, of course, to clean the stomach, the colon, take time to good exam, and after that to look for far lesion, close lesion with chromoscopy, magnification. I think we need to every day to teach to reinforce the importance of the detection and the good classification, and after that to choose the best treatment. Usually everybody wants to treat, but
That's right.
sometimes the step before is lack.
That's probably most important part to start the treatment.
Yes.
Do you agree?
Yes, completely. Yes.
Great. Yeah. Thank you so much. Now, Makoto, do you have any questions to Nelson?
Yeah. Thank you, Nelson. It was so nice presentation, and I really surprised you visited Japan so multiple times. And I think you are a very special guy who learned Japanese style diagnosis method and ESD technique as well. So, but how? Yeah, I have a same question. What was the most difficulty when you started ESD in your hospital? Did you have so many pressure or resistance from surgeon or hospital or department?
No. In relation, because our institution have a very close contact with Japanese endoscopy school. So it's for a long time. So the Japanese endoscopist way, it's very welcome in our institution by surgeons. So we don't have any resistance to start ESD. But the difficulty is we didn't have adequate electrosurgical unit, for example, CO2 insufflator or adequate knife. It were the more our difficulties.
Get the tools.
Yes.
Yeah. Do you have pretty much all the variety of tools currently in Brazil?
Yes.
All the knives?
Nowadays it's getting better, but it's not enough. I think we need to have more options.
Yes. Yeah. That was a huge issue in the United States. We did not have approved device for so many years. In the past, I was kind of self-importing myself and disclose to the patient, this is not approved device in the United States, but this would help you getting rid of the tumor, so let me use it. That consent process had to be done before the procedure when we didn't have approved device. So I feel that the pain you went through.
Yeah, yes.
Okay, so let's open to this discussion. The training is always an issue, and we as a gastroenterologist, we're very competitive. So sometimes I feel like we have to put in some competitive mode the scoring system, who's going to get the highest score. The speed is not the issue that I try to stress, but that's what I'm kind of thinking nowadays. How can we make it to the competitive mode to increase the knowledge? But that's a side story. Sorry about that.
Is that for fellows, you mean?
No, anyone.
Oh,
anyone. Yeah, therapeutic endoscopy is very competitive, as you are. Well, let's go back to the sushi. The Japanese traditional sushi is so tasty, but every location has its own invention. I'm sure Brazil has its own, the inventive sushi over there. And over time, I felt as it is okay to have local modification because the disease process is different, challenges are different, and the acceptance is different. So I think we're heading to a little different direction, as exactly how Makoto said. We have different flavor of the ESD in the United States. The most different flavor is robotics. I know Philip Chu in Hong Kong, he's doing fantastic work on robotics, and also he's a surgeon as well. Do you think robotics would play a major role in the future? Makoto.
Yeah, I think so, because we have so many out of indication ESD, so it's not Japanese style, so we need to modify to American style. So I think that's a good idea to combine robotic cases, robotic surgeon. Actually, in my institution, I have been collaborating with upper robotic surgeon for very difficult gastric ESD cases or the submucosal tumor.
Mm-hmm. It's sort of, you mentioning, it's almost like endoscopy, laparoscopy, collaborative surgery.
All right. Similar,
That's
yes.
right.
Mm-hmm.
Laparoscopic endoscopy.
Robotic.
Yeah, robotics. But to me, if you have a secure closure and the way to make it faster, we don't really need a robotics. We probably need a simple traction to make it quicker and safer, or do the full thickness resection with safe closure. That's where my question comes. Do you think robotics will be major player?
Yeah, I don't think for intraluminal treatment, the robotic is a kind of different treatment strategy. So I mean, if that is not a good indication with ESD, we can choose as one of the option. But for intraluminal treatment, I agree that maybe traction device or pocket occlusion method is a very good to treat such kind of difficult patient.
Right. Nelson, do you have your opinion about robotics?
No, I think to Brazil, I think the cost is the problem. So I think I agree with you. Maybe for many cases, less more cost effective, and it's better maybe. Robotic, it's only to maybe few specific cases, probably, I think.
Great, thank you. Thank you for mentioning about the cost. It has a lot more implication, and when we shift more to the robotics, the costs increase so significantly. So we have to really find out what's the true indication for robotics, what's the benefit truly are. So thank you.
Even device, it's so expensive, like a Lumendi, so 2,000-3,000.
Yeah, that push the cost. So the next question I have is Nelson. You mentioned about the ESD indication, but we didn't hear the ratio. What is your main ESD target in Brazil?
Okay. As you know, Brazil, it's we have a very mixed different parts of the world. So, for example, we have almost 2 million of Japanese descents. So we have this population has a very high incidence of gastric cancer, also almost also in Japan. And if we have a very high Caucasian, high level, economical level, so we have a very high incidence of colon cancer, and the poor population has high incidence of esophageal cancer. So depends on the institution we work, we have different cases. So in average, we have almost the esophageal, gastric, and colon cancer is almost the same. Maybe
Very
colon,
interesting.
it's a little higher than stomach. And later in the third position, esophageal ESD. Yes.
Great. A very interesting perspective. Thank you. And
Thank you.
which location do you think is most difficult?
I think it's colon.
Colon.
Yes. Colon, yes.
Outside the rectum, I believe. Right?
Yes, settle. Everybody say that easy, but I think rectum ESD, because of the very big vessels, sometimes it's not easy. Sometimes the descending colon, ascending colon, it's easier than rectal ESD. I don't know what Dr. Nishimura think about.
Makoto?
Yeah, I agree. So for me, I see valve region is difficult, but if the patient has a previous intervention, even rectum is difficult, but rectum is fine. So no need for worry about perforation too much.
Yes.
And duodenal case near the papilla or including ampulla is super difficult. Technically it's fine, but the management. So so immediately after the duodenal ESD, we usually put a stent, but sometimes pancreatitis happen.
How about defect? Do you try to close all the defect in duodenum?
No, usually impossible. It's many times I have a very huge lesion in second or third portion.
I see. How about in the colon? What is your practice? Do you try to close all the large defect to reduce the post-operative complications?
So I think Dr. Aihara is doing the outpatient ESD, and sometimes we do, but most of the patient I recommend to stay 1 night or 2 nights, and especially for the patient who is taking blood thinner, I try to suture. Yeah, of course, depends on the size of the defect.
Okay. I have been doing the outpatient ESD for years and years, and I only selectively admit patients, and they do fairly well with the giving instruction what to look for. And that has been really safe practice to me. Nelson, do you try to close all the defect in the colon, or is it necessary?
Yes. When we needed to discharge the patient, we try to close. Or when we have very big vessels with, if I had the bleeding with the hard control, and I use a lot of coagulation, soft coagulation. So sometimes I try to close these parts, or sometimes patient needs to take anti-plaquettes medication. So yes, so I try to close in these situations. Yes.
Okay. Thank you. So we agree that on the situation, case by case, we try to close to mitigate potential future complication.
Yes.
The delayed perforation is the worst thing we can have. I mean, we can perforate, but we can fix it. When they come back with a perforation, they always almost 100% they have to go to surgery. So I think it's cheaper to prevent perforation, delayed perforation, than just wait and see. So I agree with your approach.
Thank you.
Nelson, do you have any questions to Makoto?
No, no, only to congratulate for your job. It's fantastic. Yes, to move it to United States. So how I would like to ask you, how is to move from Japan and to United States? It's
Yeah, actually, because I had an experience of the clinical in California before, so that's why I was recommended to move to New York. Yeah, so my institution was looking for somebody who has a clinical experience in the US and ESD skill, so not much.
So in future, you will back to Japan?
I want to stay. Yeah, I needed to train more and more fellows, and I want to teach the real sushi. Not Dragon Roll, not California.
Okay. Yes.
Well, good luck. There's millennials coming in. It's very difficult to teach them that way.
It is.
Great, fantastic. It was great discussing the aspect in ESD in America, Northern and Southern. We have difference in the difficulties we face, but we're seeing the similar lesion, and we try to save the patient with the much less invasive procedure. So congratulations to both of you being so successful in each institution and helping the North America and South America. Thank you so much. It was a great session, and congratulations to both of you.
Yeah, thank you so much. Yeah, it was great.
Thank you.
Great session.
Thank you very much.
Thank you. Bye-bye.
Thank you.
Bye.
Bye.